in. And we are now in recording, and I'm going to go over to Facebook while we're getting all set up here and the people are popping in. And here come the people. That's always a good sign. And there is no description in the Zoom room. How am I going to do this? I don't have the written. Okay. On a page. Okay, everybody, as you're populating, we're getting ready to go live on Facebook. So settle in, grab your popcorn, your water, I hope, and get ready. We're going to have a nice educational fun night. So let me get, we're having a problem with Facebook, guys. It's not connecting to my page. Nope. We have a problem. Houston, we have a problem. Okay. Give me a second, ladies and gentlemen, while we get through this technical difficulty. For whatever reason, Julie, the Facebook is not allowing me to choose the HCMA page. It's just like I can do it on my personal page. I might be able to do it in a group, but I can't do it on the public page. I can do it in the private group, or I could do it on YouTube, guys. What do you think?
I would do it in the private group because it'll get uploaded to YouTube tomorrow.
I'm not sure that Julie's going to be able to download it from the private group.
I can.
You can. Okay.
Yeah.
All right. We're going to the private room. So Julie, why don't you go into the Facebook main room and tell them that if they want to watch live, they have to go to the private room or join us on Zoom.
You got it.
Okay. 3, 2, 1. An unknown error has occurred. I don't know.
I think Facebook likes us tonight.
Facebook
Just do YouTube.
is having a little bit of a.
I'll direct them to go to YouTube or to join us.
Okay. Don't know what that's about. Sorry, guys. So let's go over to YouTube. Let's hope that one works today. Still not working. Please grant access necessary for streaming. I already have. So it looks like, okay, we have a question already. Hi, everyone from Barb. Hi, Barb. I don't know that we're going to be able to stream simultaneously this evening. Technology seems to not like us. I'm going to close this out and try one more time from scratch. My apologies for the delay in starting this evening. Technology just does not want to be my friend. Nope, no matching. Nope, no matching. Okay, so Facebook is not letting us go. One more try for YouTube. This has never happened before where both of them have failed. Go public, go live. Please grant necessary streaming action. We are just going to be in a regular old Zoom room today, people. So we will post this post-production on the Facebook page and the YouTube page. Sorry about that. We'll be pulling it directly from Zoom. Good evening, everybody. I'm Lisa Salberg, founder and CEO of the Hypertrophic Cardiomyopathy Association. I just noticed my light is not on, and it's not a party until we have a light on. Okay, now it's party time. We can start talking about really exciting things like hypertrophic cardiomyopathy. Yes, people, I can get excited about HCM. So tonight I want to just do a quick introduction of some of our team that's here tonight, and then we're going to hand it over to Dr. Berenbaum, who will introduce us to the KU team. So tonight we have joining us in the back of the house, Stacy Titus Brown and Julie Russo. These are names that may be familiar to some of our volunteers and our partners out there. Stacy is our Center of Excellence Coordinator, and Julie is our Volunteer and Legislative Advocacy Coordinator. And if you're interested in being involved in any of our advocacy programs or want to do a share your story, Julie is the person that you'll be working with. But you're not going to see their smiling faces all night because they're going to disappear in a minute and go backstage. And if you have any technical questions about the use of this group or this page, you can speak to them in the chat. For questions for our faculty for the evening, we're going to ask you to use the Q&A box located at the bottom of your screen. And while I'm thinking about it, I'm going to load the poll right now. And we are going to ask you, as you're populating into the room, to please take a moment and take the survey so we know who you are and what's on your mind tonight. So I'm going to hand off to Lauren Birnbaum, who I always do this when I introduce people. I explain how long I've known you. And Lauren, I don't quite know how long I've known you. It's got to be well over 20 years now. And yeah, it's got to be over 20 years. So why don't you introduce us to your team and tell us a little bit about what's going to happen tonight? Lauren, on you.
Yes. Can you hear me?
We can hear you.
Okay, let me see. There, I have a slide.
Oh, yeah.
So I'm gonna say we met at ACC when I think HCMA was basically you. It was over 20 years ago, but somewhere in that neighborhood. And you were handing out little 3x5 cards with a quiz on HCMA.
Oh, wow. That was a long time ago. That's like
Yeah.
25 years ago.
And
And Lauren just disappeared. He hit the wrong button. We are having a technically challenged start to this event. He'll be back in a moment. He'll be back in a moment. Okay, so that was the, we are in for a whole world of firsts tonight. I'm getting a little nervous, people. We do have some really great content coming for you if we can get everybody on the page. Let's just see about getting him back. Sometimes they lose internet and sometimes they hit the wrong button.
It's part of the magic show that we're doing here.
It is the magic. See, I turned on the light and everything went sideways.
Yeah.
Are you coming back? Okay. So anyway, we're gonna wait for Lauren to come back and introduce it. Oh no. The text didn't. Something's gone amok. Not even the text went through. Maybe one of you guys could throw him a text. So I'm going to let you guys go round robin and introduce yourself. Tom, you go first.
Okay, I just took off my mute button, so I hope we're on target here.
We can hear you.
Yeah, I'm the director of advanced imaging at KU Med Center, and I'm going to talk a little bit later tonight, or when you give me the high sign, just some examples of what we're talking about structurally from a visual aspect of pictures. So that's going to be my role tonight.
Fantastic. I'm going to do it. Halola. I did it wrong.
I like it though. I like it. So my name is Paola Roldan. I'm one of the heart failure transplant cardiologists here at KU. Also work in the hypertrophic cardiomyopathy field as well, along with a couple other colleagues. And I'll be talking about septal reduction therapy.
Fantastic. And we're going to go to Farah next, who's on my screen. I'm going the girls first here.
Hello, my name is Farah Amori. I'm a genetic counselor, and today I will be discussing the genetics of hypertrophic cardiomyopathy.
And I'm going to do it again, and I've tried already. I cannot pronounce names today.
Herrick.
Herrick.
Yeah. Hey,
Dr.
so
Shaw.
I'm one of the advanced heart failure cardiologists and transplant cardiologists at KU, and also do hypertrophic cardiomyopathy as well. And I'm going to talk to the group about myosin inhibitors and its role in current day practice.
Fantastic. And while we're waiting for Lauren to come back, John, why don't you say hi and tell everybody why we're going to know your name real soon.
Oh, thanks, Lisa. I'm John Fritzen. I'm one of the second-year cardiology fellows with a special interest in HCM, and I've been working with this fine group for last year and have another year with them before staying on with the group at KU, and going to be taking extra time to seek out externships and really get entrenched in the HCM community. So hoping to kind of fill some big shoes one day, but hopefully, anytime, in the immediate future.
Fantastic. Okay. So while we wait for Lauren to come back, oh, that's Stacy. Hi, Stacy.
Hi. So Dr. Barenbaum is actually supposed to present last. So if you want, you can keep on continuing your presentation and hopefully he'll be here shortly.
Okay. Why don't you try to reach out and just let him know that we're all waiting for him and
Yes.
that we're going to be carrying on. Thank you so much.
Mhm.
Okay. So I'm going to kind of get started with my talk real quick. Please remember to answer the poll. When I'm done with my talk, we will look at the poll answers. I do have one slide that I'm going to try to pull up for you. Let me just get into slideshow here. That I'm going to go kind of quickly through my talk and just kind of give you some highlights. And then I'm going to try to play a video that is out here as well. So you're going to see some late breaking stuff today. So again, thank you for all joining our Bighearted Warrior Tour, and we are taking it on the road next time. So, oh, Lauren's back. Okay, wait, Lauren, everybody introduce themselves. We lost you. We just kept moving. It's like a train. We just got to keep going.
Perfect.
So, okay, I'm going to do my little thing, and then we're going to bring you back, and we're going to do everything like normal. Okay, so here we are. We're all back together again. So this is your agenda for this evening. We're going to talk about myosin inhibitors. We're going to talk about MRIs. We're going to talk about managing obstruction, the role of genetic testing, and research, a very, very important topic. And thanks to all of our sponsors this evening for helping us make these types of programs possible for you and bringing learning right into your living room with world-renowned experts. So Cytokinetics, Bristol Myers Squibb, Tenaya, BioMarin, Edgewise, the rest. Thank you all so much for being partners in the past, and we have some interesting partners coming up in the future, so stay tuned for more information about all of them. So we just came out of Heart Month. It was a really, really busy month, and I don't normally show statistics here, but I just want you to pay attention to all the arrows that are going up and some of the numbers associated with them. Our social media platforms, Instagram, Twitter, LinkedIn, Facebook, all up in the triple digits, crazy numbers that we had increased. We had our Hill Day. I'm going to talk a little bit about that. We had our Awareness Day webinars. We had a lot of people show up. It's got a lot of views. Oops. And we just had a fantastic time. Next year in about October, November, we're going to start reaching out to you all about efforts for next year's HCM Awareness Day, which will be the fourth Wednesday of February. And we will be looking for more resolutions, more Awareness Day proclamations through your state, federal, and local governments. So stay tuned for more on that. This is what we did last year and the year before. So we're adding to our bling wall. There's a lot more hanging on the wall than these few, but having these certificates, proclamations, and laws recognizing HCM Awareness Day gives us a platform to discuss the issues that are important to our community. And we thank all the states who've already given proclamations, and hopefully we will get more and more next year. That's where we're going to start in October, so we can show everybody how to work with their states to get us on the calendar. So we went to Capitol Hill, and I'm actually going to do something here. I'm going to try anyway. And you're going to probably get a little ad space here first. And I'm going to jump this forward because it's a promo. So when we went to the Hill, we brought a young man by the name of Jared Butler. He plays for the Washington Wizards. He has hypertrophic cardiomyopathy, and he's playing professional basketball. And this is a piece that was, oops, you know what I'm going to need to do? Hold on one second.
Jared Butler would.
I have to stop sharing. I have to share with sound. Hold on one second. Share with sound. Share with sound. Share with sound. Share with sound. So here's the story of Jared Butler, and a little bit, you'll see some names and faces and logos that you'll recognize. So here you go.
Was diagnosed with a condition that almost derailed his NBA career. So Jared took a trip up to the Hill to educate the staffers on a condition close to his heart. And I had the honor of sitting down with this impressive man to discuss his experience.
With HCM, the hypertrophic cardiomyopathy, we look like everybody, we look normal, but we have abnormal hearts. We came to the Hill to ask for help from the government to help us find the undiagnosed. We want to save lives.
Today I have the honor and really the distinction to introduce you to a young man who does care about others. Ladies and gentlemen, please help me welcome Jared Butler.
Really appreciate that. Good evening, I'm Jared Butler, and I'm so excited, so fortunate enough to be here today, and for two reasons. Number one, y'all look pretty good. Not gonna lie to you, y'all look well dressed. I need to kind of step up my game. Number two, I just have a big heart. I mean that figuratively and literally. And from this big heart, I just kind of wanted to share my story and things that are important to me in hopes that they become.
Hold on one second. Are we having a problem with hearing here? Do I have the wrong screen up? Somebody told me. There we go. Are we on the right screen?
Now we see the correct screen, yes.
Important to you. At around 18, I was walking into my Division I college basketball scholarship, and when a pre-play physical routine changed the course of my life. So much so that the college that I was walking into closed the door on me and closed the door on my college basketball career and medically disqualified me.
Hypertrophic cardiomyopathy, HCM, is a genetic heart condition that can affect anybody from a wide range of people. And basically, not to get in too much in the weeds of it, but the wall thickness of the heart is thicker, so to speak, than a normal heart. And it's a wide range condition, and a lot of people don't know they have it.
Without this routine physical, I would have gone undiagnosed and unaware of the state of my heart. And who knows, I wouldn't be here today speaking with y'all beautiful people. I wouldn't get this chance.
Well, most people find out around like 50, 45 when they start going
What?
to tests. Yeah, you know what I'm saying? Because now they're starting to go get their heart checked out as like part of the.
You're right,
you know,
that makes sense.
Yeah.
But you found that at what age?
18.
18.
Yeah.
So like, what was that kind of just the emotional reaction to that? Because
Yeah.
obviously you're an athlete before that.
Right. So up until that point, I felt totally fine, and I still feel fine. I didn't feel any symptoms, but just hearing that you have a condition and, you know, what does this mean? What does this mean for my life? What does it mean for sports? And it definitely impacted my sports life and kind of like moving forward. But it was just kind of like, it hit me like a truck because number one, I didn't know. And this whole time I've done every sprint, every practice, every game. And, you know, I didn't know it, so.
Jared, I know it took a lot of courage to publicly talk about your condition. My question is, what would you say to another athlete who doesn't want to be tested or screened?
I truly do think that's a great question because it's scary. When I walked in the doctor's office, I was scared. I was super unsure about what is this going to mean for my life and even my basketball career. For me, I would say your life is way more important than your basketball career, etc.
So I'm here. My 10-year-old son had a cardiac arrest at school. I got diagnosed because of him. He saved my life, and he also saved his brother's life because we all got diagnosed. So thank you guys for having the courage to speak about this. This is very personal to me. Jared, I got to talk to you a few minutes before, and I appreciate you coming out because my son would have loved to see somebody who represents him. He was a basketball player, football player, everything. He was playing basketball and went down. So, thank you.
The trip to Capitol Hill, obviously bringing awareness on the front end, but on the back end, what were some of what are your expectations and what do you want people to get from it?
First, an awareness of what HCM is and the type of condition it is. And then number two, of the importance of getting screened, getting Like I said, a routine physicals, especially in underserved communities where, you know, people aren't getting routine checkups. And just because you have HCM is not the end of your life, but it is the start of your life with HCM. So that's kind of what I want out of it.
Wise. Sage wisdom.
Oh my God.
Look at you. No, I'm serious. Like, how old are you? What are you like?
I'm 23.
23?
Yeah.
Come on, bro. No, seriously, a lot of people, when you go through life affecting moments like that,
It changes your life.
it changes it.
Yeah.
And you can either embrace it or you can reject it. And I love the fact that you're embracing it as a part of your journey and not the end of it.
Yes.
So that's wise.
That's good.
Well played, sir.
That's good.
So I gotta do a screen swap again here for you. Hold on one second. And then we'll get back to the PowerPoint and I'll tell you what else is going on here. So what we were actually doing at the Hill was starting to raise awareness at the federal level that we need to do a better job of screening adults and children for hypertrophic cardiomyopathy. And in that, we went to the Hill to ask for the Welcome to Medicare exam to start asking questions about family heart health history. And we're on the state level doing the Healthy Cardiac Monitoring Act. So I do have to point out this picture in the middle. It's my favorite. This is Marcia. Marcia's 81 3/4, or maybe closer to 82 by this point. And Jared, obviously, you've just heard his story at 23 years of age. I just love the picture of the two of them together making the little heart with their hands, because you can't judge books by covers. Both of them have HCM there, Sheridan Heart, and they're both sharing their story to show the people like them that they can live good lives with HCM. So phenomenal partnership, and we just really loved our time on the Hill. If you're interested in getting more involved with our Healthy Cardiac Monitoring Act, which is our state level initiative to include family heart health history questions in the well child examination, so on the other end of the age spectrum, we encourage you to get in touch with Julie and learn more about our initiatives. I will be going to Columbus, Ohio on April 10th. If anybody is in the Ohio area and is interested in coming to the State House to either watch testimony or provide testimony, let's meet in Columbus, Ohio in a couple of days. That will be fun. And these are some of the things that we've got to get done so that we can identify more people. For those who are diagnosed, I just want to remind you all that the Lori Fund is still available and hopefully will be available for many, many years to come, providing micro travel grants to those seeking care at HCMA recognized centers of excellence who may not have the financial ability to easily travel. So think planes, trains, automobiles, hotels, and food on the road. We want to make it easier for you to get to high volume HCM care. If you need an Uber across town and you don't have it in your budget, apply for the Lori Fund and hopefully we can help you out. If you need to fly across country to have a myectomy, we're here to help you for that too. If you need a consult to figure out what path you're on, we can help with that too. So don't be afraid to seek out Center of Excellence care and don't be afraid to apply for a scholarship. If you're in the Denville, New Jersey area, we're going to start something a little different, a little new, a little bit more local, and hopefully build this program out so that you can bring it to your own community. Many of you have heard us talk about the Drill Dr. Heart program. We actually started it back in 2011. And it is not CPR training. It is not AED training. It is emergency preparedness training for a cardiac emergency. We're going to teach you how to put all of the elements of the chain of survival into action. We're going to be great. We're going to be meeting people at opening day here in Denville, New Jersey on Little League Day. And we're going to be training the coaches the following Saturday on how to drill for their teams to be prepared for cardiac emergency. Once we get this a little bit more vetted, we'll be able to train volunteers all over the country. And you can go out to your houses of worship, to your community events, to your sports teams, and teach them how to prepare for cardiac emergency. So if you're in the area and you want to volunteer and come on down and have some fun with us and hand out some brochures and talk about HCM, come on down to Gardner Field in Denville. We'd love to see you, as long as it's not flooded, because sometimes it floods. We've added a couple of new discussion groups to our agenda as well. And we have added on the first Monday of every month, the pre-transplant pathway. If you've been advised to get evaluated for heart transplantation, you're listed for heart transplantation, this is the group for you. On the third Monday of the month, the pre and post get together and we do some education, we do some speaking. Coming up this next month, I believe we have Dr. Paul Thompson coming to speak to us about statins in the transplant population. And we were really excited to have Dr. Robert Pensack, who is a 32-year transplant survivor from HCM, come speak to us in our last session. And we're working on an ongoing relationship with Dr. Pensack. He is a psychiatrist by training and a transplant survivor of 32 years. So he really has some very interesting insights for us. So please join us in the Transplant Pathway discussion group. We have lots of other discussion groups as well. I encourage you to learn all about them on our website. For those of you who are interested in our ambassador program, we just dropped a really cute video from the ambassadors. Many of you may have seen some of these types of videos showing up on your social media feed when they say things like, you know, I have HCM. Of course, I'm always short of breath walking up the stairs. I have HCM. Of course, I'm always scheduling my next cardiologist appointment. Just to kind of lighten up the story of HCM, and our ambassadors are sharing their passion, their journey with everybody. If you're interested in becoming one of our ambassadors, they have a great time. They're putting out a lot of great content and educating thousands of people along the way. So if you want to join us, Julie's running that program as well. So I would encourage you to talk to Julie. We are going to do a really cool new webinar series starting April 25th, April 30th, and then May 7th. The Social Security Administration is coming here to talk to you. Well, all right, we're doing it all via Zoom, so they're not going to actually be in the office. But we're going to offer 3 webinars about you and your Social Security benefits. Understand how to access them, understand how to qualify, and they're also going to talk to us about their return to work program. So maybe you don't have to be on disability forever. Maybe it's a year or 2 of your life. Maybe it's longer, but we're going to learn all about how we can work collectively with Social Security Administration to ensure you get the benefits that you deserve and that you've worked for. Okay, we're on the road. We're going out there with humans who hopefully don't have COVID anymore. And we are going to be at Christ Hospital in Cincinnati on May 4th. This has admission attached to it. The admission price will all come back to the Lori Fund, which we just talked about. And this is just to kind of make sure that if you say you're going to show up, you're actually going to show up. And we hope lots and lots and lots of you show up. You all just got an email dropped if you're in the area. The registration is open online. We hope you join us in Cincinnati. And we also hope that you consider joining us October in Boston, where we will be partnering with the 8th International Summit on HCM. We will be hosting Saturday night at the summit, which is open to patients and the participants at the summit. I hope many of our faculty tonight will be at the summit. And then on the 27th at 12:30, when the summit ends, the HCMA annual meeting begins. We're just going to use the same space, and we're going to flip the room, and we're going to bring the patient's voice to the stage. So we hope that you can join us. It should be educational, fun, and it's going to get us ready for some really big initiatives coming in 25, 26. We've got a lot of things planned, and you're going to learn all about them this fall. I want to say thank you to our board, our staff, our volunteers, and our partners, of course, our sponsors. But thanks most of all to Brandy, my donor, without whom I would not be with you here tonight. And I really look forward to hearing from our speakers tonight. Sorry, I went a little bit long on my talk there because that video was a little bit longer. But now we are going to hear from Dr. Rosamond, and we're going to learn about MRIs a little bit.
Okay, thanks very much. I'll boot up the program here and get right into it. Yes, my goal tonight is just to show you some pictures of what hypertrophic cardiomyopathy looks like. And in that process, you may see images that you've never seen before. And but I'm going to go quickly, so buckle your seatbelts. First of all, it helps to know what normal is. So let's take a look of a normal heart. This is a 38-year-old guy who had chest pain and some symptoms. So they did a cardiac MRI, and this is our first look now at a beating heart as it comes off the scanner. And you can see all the fine detail of the heart and all of its different structures. And what hypertrophy usually does, it involves the muscle, so it makes the muscle thicker. This is a normal, so you can see what the abnormals look like. If you take another view, you can see the mitral valve and its structure and function. That's important in hypertrophs because there can be abnormalities there that are important. We also take a short axis view of the entire heart from top to bottom. Looks like a donut squeezing, doesn't it? But you get that vigorous, tight movement. That means the heart beating strongly. That's the normal look. If you look at giving gadolinium contrast, you can see the scar. Now, this is like a black donut, but if you see white frosting on this black donut, that's fibrosis and scar that you can see in some people with hypertrophic cardiomyopathy. And here's just a stop view of it so you can kind of see what I mean by a donut. It's kind of a black donut, but that's all your heart muscle. And if it looks bright, there's a problem. Okay, let's go to the next slide. Okay, so here's our first case. What does an abnormal guy look like? And if they have an abnormal EKG, boom, they get a cardiac MRI. And here you can really see the very thick wall of the myocardium in the septum. It's obviously much thicker than the normal wall in the lateral area over here on the left-hand side. When the wall gets thick like that, it's often cardiomyopathy. And here's the gadolinium views that show a scar. See how that white donut has white frosting? That black donut has white frosting? That frosting piece, if you will, is scar tissue. And that's where the arrhythmias come from that are a danger to life and limb in terms of living with hypertrophic cardiomyopathy. And the doctors will want to know what that looks like. Let's take another example. A 43-year-old male who has an echocardiogram, and the echo says that the walls are a little thick, but not much. But it leads to a cardiac MRI, and it reveals this thick wall again in the middle of the heart. It's not as dramatic as that other person, but you can see that it's clearly thicker than the other side of the heart. That's an abnormal buildup of myocardium that's usually a genetic issue and is what hypertrophic cardiomyopathy is all about. If you look at this picture of edema, you can see that portions of the donut in the middle portion have this bright signal. That's edema in the myocardium itself. That's another clue that we're dealing with hypertroph. And if you take this picture of this gentleman, you see all this white frosting in that part of the myocardium that should be black is now white, and that's scar tissue. And here's just another example of it here at the tip of the heart as well, into the right ventricle as well. So that's fairly typical. Now let's take another example. 60-year-old gentleman who has an abnormal echo, and they call it left ventricular hypertrophy, and he has AFib ablation. But they're worried that he might have hypertroph too that's unrecognized. So they do a cardiac MRI. And here's the initial shot. And you see that the myocardium in this basal segment is a little thick, but it's not definitive. But you see the mitral valve leaflets, how they bend back on themselves? It kind of has a reverse curve here. It touches the septum. That's systolic anterior motion of the mitral valve and is a fairly characteristic example of what it looks like in hypertrophs who have outflow tract obstruction. On this particular case, he had no delayed scarring tissue, just that systolic motion. But on the strain imaging, you see that yellow segment of the heart, that's abnormal strain. And that's what led us to make the diagnosis of this gentleman that he had true underlying hypertrophic cardiomyopathy early on. How about another example? 54-year-old gentleman has a heart murmur. You see that all the time. But this guy, the pressure inside the heart goes up dramatically when they exercise, while they're out running wind sprints, for example. And 185 is very high blood pressure in the heart. So our job with this heart was to determine if this was another hypertrophic cardiomyopathy patient. So we did our scans. And at first blush, this doesn't look too abnormal. There's a little thick here, but not much. But when you do the flow scan, that thick part of the base of the septum shows all this black turbulence in the outflow tract. That's disruptive flow in the LV outflow tract. That means it's consistent with a gradient and is one of the markers of hypertrophic cardiomyopathy. And in secondhand reference, you can see that the mitral valve here also leaks because that anterior leaflet is being dragged into the outflow tract. That's a pathologic problem with hypertrophs. How about another lady? Not everything's hypertroph in the world, so you have to know the difference. This is a 46-year-old lady who had triplets, and I was seeing her for a heart murmur, and everyone thought it was hypertroph. But when you look at the actual images in close detail, the mitral valve is okay, but she has a web in the outflow tract. That's also a rare congenital abnormality. It's not hypertrophic cardiomyopathy, though, so it changes her whole outlook on life and raising her triplets, who were just young children at the time. What about apical hypertrophs? This is another variant. Some of you may be familiar with this. It maybe have a slightly better prognosis, but it has a different look entirely. So here's a 68-year-old gentleman. He has no symptoms. He's being evaluated. He's got an abnormal EKG with T waves that are upside down. You take a look at the scan, and even someone who's not seen these before can see how thick that heart muscle is. It's just like Arnold Schwarzenegger on steroids thickness. It's out of proportion to what the heart really needs. That means it's hypertrophic, and that is an example of apical hypertrophic cardiomyopathy because the apex is very thick. And it's pretty obvious for most people to see what I'm getting at there. Here's a still shot just to show that the apex, the top of the heart, the tip of the heart is very thick and not normal. It's from hypertrophic cardiomyopathy. And here's that scar tissue. This is the frosting on the donut I was talking about. That's scar tissue in the apex. That's what causes arrhythmia in many cases, not everyone. But there's another type of apical hypertrophy that you need to know about, and that's the one that has ballooning. And this is a 75-year-old gentleman, has an elevated calcium score. He's got an abnormal echo. We do an MRI, and you see this big, thick apex of the heart, but look at this balloon out the tip of the heart. That's from the stress of that constant muscle contraction. It creates like a bleb on a tire that's about to blow out. That apex is ballooning and dilated. That's also a marker in apical hypertrophy. And here's another shot at a different angle. You can see the white frosting again on the tip of that ventricle, that scar tissue from the hemodynamic effects, the pressure effects of that constant apical hypertrophy. But there are others. There's still other types. This is an eccentric hypertrophy that you may not see too often. 23-year-old gentleman. He has an abnormal EKG at a screening exam when he was only 15, but they didn't do anything about it. So 8 years later, he's starting to get dizzy. And look, but behold, he has abnormal genetics, and this is what his MR looks like. You see that big, thick muscle there? It's off to the side. It's eccentric, but it's quite thick compared to the rest of the heart muscles that's squeezing normally. That's an eccentric hypertrophic cardiomyopathy. And how do we know that's true? Well, we look for the frosting. In this case, the white frosting is not there. But if we do parametric imaging, which is measuring the fibrosis directly from the signal, the so-called T1 maps, you see it lights up like a stop sign over there. That all that yellow stuff is bright as can be. That's all inflammation and fibrosis in that thick area. That's also hypertrophic cardiomyopathy. As I end up here, I want to show you cans and wires. What I mean by that is many people with hypertrophy end up with pacemakers and defibrillators, not everyone, but as part of that, we commonly see it in MRI. And here's an example, 67-year-old gentleman has a pacemaker in, and they want to know if they need to upgrade to an ICD. Well, here's his scan. And 10 years ago, I wouldn't even be able to show this picture, because if you had a pacer wire like that in the right ventricle here, that long tubular black thing, we wouldn't even try to do this. But nowadays, probably many of you know family members or other people who've had scans with pacemakers in. And this one's a hypertroph with a pacemaker in situ. And that thick basal septum, it's obviously thicker than everything else. And here's our white frosting on the donut right here. That's all scar tissue in the base of the septum, kind of a classic look for hypertrophic cardiomyopathy. And here's just a short axis view with the pacemaker wire in place, but you can still see the scarring, which is a marker in some cases, or some people believe it's a marker for higher risk and maybe an upgrade. And then there's just a still shot with the frosting. And then this is the last thing I'll say, and then I'll move on. There's a solution to some of the artifacts with pacemakers that some of you may have run into. It's called wideband imaging. And here's an example of the hyperintense, that looks like hypertroph in the left-hand panel, but that's actually a hyperintense false signal. If you do wideband, some of you may have already had this, it eliminates that artifact, and we can start to see whether or not there's scar underneath that area. So having an ICD and doesn't eliminate our ability to look for scar in hypertrophic cardiomyopathy. So in summary, it's the most common genetic cardiomyopathy. 1 in 500 adults have it. It's highly heterogeneous. It can be everything from completely asymptomatic to very life-threatening. So you have to know what things look like to identify them, and that's what MRI is all about. And with that, I'll go on. Thank you so much.
You did a quick wrap there. Had to hurry up and get to the bumps. Okay, do we have any questions regarding MRI? I will just start with one quick question. As technology advances, and I'm curious the input for the rest of the crew here. People have asked me, why don't we just do MRIs? Why do we bother doing echoes? And like, we get different information from different imaging technology. But there's always this, not always, but often a concern that the MRI images seem to have larger measurements than the echo images. And I try to explain to people that it's different scale, it's different line delineation, and not to worry when their MRI and their echo wall measurements don't exactly match. One might be a 1.8 and the other's a 2.0. We tend to see the MRI images a little bit thicker than the echo images. Can you just discuss a little bit about why people might see that and why it's not something to panic about?
No, I think it's basically just an intrinsic property of how high resolution MR is. It doesn't mean the echo is misleading. It just means that the MRI can more accurately map out the distances and thickness. So if there's a question with an echo, the right step is most cases do an MRI for precision. But don't be surprised if the echo looks a little different. That's part of the mix. You're going to see that all the time. It doesn't mean that they're wrong. It just means you need to go the next step if there's any doubt. I think hypertrophic cardiomyopathy is a challenge anyway, regardless of the imaging, but I think there are good reasons to explain the differences.
So you have made Lena very hungry for frosted donuts. She just wanted to tell you that. Okay, so we are going to go on to talk about myosin inhibitors now. And it's probably the hottest topic in all of HCM. Let me just stop your screen share and we'll get on to the next. The hottest topic in all of HCM is, well, when can I get one of those fancy new myosin inhibitors? And we're going to have Dr. Shaw from Advanced Heart Failure and Transplant, a matter near and dear to my heart. We'll talk a little bit about that later. To talk about where are we with myosin inhibitors in today's world. And right now, I have to tell you, outside my window is the most gorgeous sunset I've seen in New Jersey in a long time. The sky is orange and gorgeous. I'm going to try to take a picture for y'all. Okay, Dr. Shaw, the stage is yours and the slides are set. And
Can you guys hear me okay and look at my slides okay?
We are good.
Okay, thank you for the opportunity for me to talk about myosin inhibitors. I really am excited about this topic. I think this really represents a new paradigm shift in how we manage hypertrophic cardiomyopathy, and I'm very, very excited for the future for these medications. So as Dr. Rosamond's kind of alluded to, hypertrophic cardiomyopathy is the most common genetic abnormality that we have in cardiovascular medicine. It's around 1 in 500, but as we get as people get more in tune with this and are actually thinking about it, I wonder if that incidence is actually going to decrease and we're going to see more and more patients with hypertrophic cardiomyopathy. But it's really defined as left ventricular hypertrophy. So you have a thick wall of your heart and it's unexplained by loading conditions or secondary causes. What I mean by that is that it's not because your heart's been pumping against a high blood pressure or you have a valve that's really tight. There's something intrinsically wrong with there's something intrinsically happening to the muscle where the muscle becomes thick. And the management of hypertrophic cardiomyopathy has really been focused on, making sure these patients don't have atrial fibrillation, don't have ventricular arrhythmias. And what I'm going to talk about is heart failure. And what I mean by that is shortness of breath. Patients are not able to do their basic activities. They're not able to walk up the stairs or kind of, do basic activities with their family. And when you take a look at why patients have the symptoms, we usually group them. I'm sure many of you guys know this, but we group them in kind of two kind of categories based on their physiology, whether they have obstructive hypertrophic cardiomyopathy or non-obstructive hypertrophic cardiomyopathy. The MRIs, I think, show it a lot better than this cartoon that Dr. Rosamond showed. But again, kind of showing an obstructive hypertrophic cardiomyopathy, you have this thickened muscle that prevents, and this mitral valve abnormality that prevents blood going through your aorta, which is your main blood vessel that goes to the rest of your body. And so depending on what physiology you have, there's different ways we can treat it. I'm going to first focus on obstructive hypertrophic cardiomyopathy because around 2/3 of patients with HCM will have some sort of obstruction. And I'm going to first talk about what the original or traditional algorithm was. This is kind of maybe 5 or 6 years ago, or, like 10 years ago, of how we were managing patients with obstructive hypertrophic cardiomyopathy. If patients had no symptoms, we would not have any therapy. We would not recommend any therapy. But if patients did have symptoms, again, shortness of breath, chest pain, inability to do their basic activities, we would recommend as first line, we would start them on a beta blocker or calcium channel blocker. If that didn't work or they still had a gradient, we would start them on a medicine called disopyramide. And also, if that didn't work or in conjunction, we would look into looking at septal myectomies or alcohol septal ablations. But when you take a deep dive into why this algorithm exists and you actually take a look at what does this algorithm actually work, you actually find some very, unique findings. First, when you look at the data of these medicines and these therapies, there really isn't a lot of data, and I'll show that in subsequent slides. Second, none of these therapies really attack what the underlying mechanism of why patients have hypertrophic cardiomyopathy. And then third, I think most important for patients, these medicines may not be well tolerated. I think many of you might have been on a beta blocker, know people on beta blockers. Beta blockers work, they do decrease gradients, which I'll talk about. But patients, it also decreases heart rate. It also decreases blood pressure. And especially for younger patients, they really don't tolerate this medicine. Patients feel fatigued. They get this brain fog. It's not very well tolerated. And especially disopyramide. Disopyramide is even more untolerated. These patients have incredible anticholinergic side effects. They have constipation, urinary retention. Most of them have to go into the hospital because there's a risk of ventricular arrhythmias when you start this medicine. And so these medicines aren't well tolerated. So I think this traditional treatment algorithm has a lot left to be made. So when you look at metoprolol, again, it's the first line medicine. But when you look at trials that looked at metoprolol, the first randomized trial was actually published in 2021 and only had 29 patients, which I think is crazy when you think about trials that we're doing in cardiovascular medicine, how a class 1 recommendation only has 29 patients. But metoprolol has been around for a long time. We've used it in many other cardiovascular conditions, and there's a very powerful safety effect of metoprolol. But specifically in hypertrophic cardiomyopathy, when you actually study it in obstructive patients, we do see that it does reduce gradients, but about a third of patients don't have a response. But I think very important, when you think about a drug that you're using to treat a condition, I always think about it is that we need to make people feel better, and we need to make patients function better. And we measure that by different things like NYHA class, KCCQ, stress tests. And when you actually look at metoprolol, these patients actually did not feel better on this medication. Their health quality assessments were actually very similar compared to placebo, and there was no difference in exercise capacity. So our first line therapy works in reducing the gradients, but again, doesn't make people feel better or function better. Surgical myectomies, Dr. Roldan's going to talk about this. I think surgical myectomies are very, very effective. But the one thing I want to say about surgical myectomies is that it's an anatomic modification of an underlying disease process. So even though the surgeon can go in and kind of remove the area that's thickened, the rest of the heart still has the same genetic abnormality that caused hypertrophic cardiomyopathy in the first place. And I really love this study in 2022 that looked at patients after a surgical myectomy. 17% of them developed atrial fibrillation. And atrial fibrillation in HCM is basically a marker of adverse remodeling of the heart. So even though they had surgery that cured their obstruction, their heart still can abnormally remodel, and they can form atrial fibrillation and heart failure afterwards. So the therapy is effective, but it's not a cure to the underlying condition. So I hope I've created a kind of a framework that our current treatment algorithm for hypertrophic cardiomyopathy does work, but there's still a lot of unmet needs. And I think myosin inhibitors really have a great opportunity to fit these unmet needs. So in order to understand how myosin inhibitors work, we have to go back to the basics. We have to take a look at how the heart works. And if you can see on this right side, is that when you take a look at how the heart contracts, it's really a combination of two molecules, actin and myosin. Actin's on top, this thin filament, and myosin's on the bottom, this thick filament, that has these heads that kind of look like oars on a rowboat that kind of move myosin along actin. And that movement is actually what causes the heart to contract. And normally, around 50% of these heads are bound to actin because this whole process requires a lot of energy. And 50% of the myosin heads are in this relaxed state, which kind of saves energy. But the problem in hypertrophic cardiomyopathy is that there is an abnormality in myosin or actin where now you have increased a number of myosin heads binding to actin. And so now you have more myosin and actin interaction. So it actually makes the heart contract a little bit stronger. That might sound great initially, but actually that has a lot of side effects. One, because this is such an energy dependent process, your heart is now using way more energy than it should. And then the muscle actually starts becoming damaged because it's using so much energy. And second, as the heart basically contracts much harder, it works like any other muscle. It's going to start becoming thicker and thicker. This is not like our bicep that we want to, make bigger. This is one muscle that you probably don't want to make bigger. Not probably, you don't want to make it bigger. And so by having too much actin and myosin interaction, you actually can cause, fibrosis and myocardial damage. And so what cardiac myosin inhibitors, the goal for what they want to do is actually try to limit the interaction between actin and myosin, try to restore that interaction back to how it was with 50% of the myosin bound to actin. And by doing that, you then decrease the contractility of the heart, you improve the energetics of the heart, and hopefully by then you actually make the heart remodel. And so the first myosin inhibitor that came to market and came to study was mavacamten or Camzyos. And this is an animal study kind of looking at a mouse model of HCM. And you can see this mouse model has HCM. This wall is very, very thick. And you can see this kind of, again, the frosting on the donut that Dr. Rosamond had. This is the fibrosis that is seen in hypertrophic cardiomyopathy. And when these mice were treated with mavacamten, you actually can see their walls became much thinner, normal, and their fibrosis went away. So this was really, really interesting because maybe since this medicine is going after the reason why patients have hypertrophic cardiomyopathy, there's a lot of promise on how these medicines can work in the long term. So how do these medicines work in human trials? So many of you might know about the Explorer HCM trial. This was a phase 3 trial looking at mavacamten. They randomized patients, 251 patients, to placebo or mavacamten, and they looked at it for 30 weeks. And what they found, again, is they looked at, do patients feel better and do they function better? And so when you look at NYHA class, there was a significant improvement in the NYHA class when patients took mavacamten, very different than metoprolol. And when you looked at cardiac performance measured by peak VO2, which is a stress test, they found that there was a significant increase in peak VO2 greater than 1.5. Some patients even had greater than 3, which is a huge improvement in cardiac performance. So these hearts work better and patients feel better. And that's, I think, a big win for patients who have hypertrophic cardiomyopathy. Why does it work? And when you actually look at the gradients, these gradients in the beginning of in the study, these patients had gradients of 50 or above. And right away, you can see once you started blue is mavacamten, you can see that right when you start the drug, there's a significant reduction and sustained reduction in the gradients. Also very important is that, how I said, when the hearts get thicker, these hearts can get damaged and fibrosed. We can actually measure myocardial damage in the blood, and we use what we call cardiac biomarkers. And two of them that are most commonly used are NT-proBNP and troponin. What I would say is these are markers that really look at myocardial stress and myocardial damage. And when you start and you want these numbers to be low. When you start someone on mavacamten, you can actually see that their NT-proBNP dramatically is reduced. And there's many, many clinical trials that have shown in any cardiovascular disease, if you're able to decrease NT-proBNP, that leads to decreased hospitalizations and decreased mortality. So this is a very powerful finding that this medicine decreases NT-proBNP. Same with troponin. Troponin is dramatically reduced as well. So there's less myocardial damage happening when patients are treated with myosin inhibitors. The important thing is that when you take a look at myosin inhibitors, is that the idea is that you want to reduce actin and myosin. And I think one of the biggest fears of this medicine is that what if you overshoot? We're trying to treat over interaction between actin and myosin by inhibiting it. But what if you inhibit it too much to the point where then the heart doesn't really contract well? And so that's why we look at ejection fraction very, very closely when we have patients on this medicine. And when you look at the Explorer cohort, around the average reduction is around 4%. And we expect that there was going to be a reduction because, again, you're having less cross-bridging. Around 7 patients, around 5% of patients actually had to temporarily stop the drug because their ejection fraction went below 50%. And the important thing to know is that when you basically stopped the drug, these ejection fractions got better. So the interaction between actin and myosin with this drug is reversible. And so it's something that we have to watch, but only 5% when you have a lot of patients have a significant benefit. So the other trial that I think is even more powerful than Explorer is looking at the Valor trial. This is a trial looking at patients who were the sickest of the sick, in my opinion. These are patients who were referred for surgery or septal reduction therapy. And so these patients were very symptomatic, had very, very high gradients. And the investigators asked the question is, okay, let's take a 16-week pause. Let's try mavacamten or placebo and see if you still need to have surgery after you try this medicine. And what they found was that, again, like Explorer, there was a significant reduction in gradient. But very powerfully, 100% of these patients needed surgery when they first started this trial. The patients who got Camzyos or mavacamten, 4 out of 5 of them did not need surgery after they started the drug, which I think is a huge, you take the sickest, the most symptomatic patients, and around 4 out of 5 of them might not need surgery. I think that's a huge, huge treatment effect for this medicine. This trial did not compare mavacamten versus septal reduction therapy, but I think what I take away from this trial is that, septal reduction therapy is very, very powerful. Camzyos or mavacamten is very, very powerful. Now the patient has a choice. Do they want to go ahead and get a surgery done and not be on a medicine, or do they not want to get a surgery done and then go on medicine? I think this is really just good for the patient because now we have multiple options to treat a very, morbid condition in terms of symptoms. One of the best parts about this field is that now, before the original treatment algorithm, there was not a lot of, specific therapies for hypertrophic cardiomyopathy. Now there's more and more coming down the pipeline. We have gene therapy, and we also have aficamten, which is a next generation myosin inhibitor. I don't have time to talk about why it's called next generation, but if someone has a question, we can definitely talk about it. But this has been studied in a phase 2 trial. Looking at obstructive hypertrophic cardiomyopathy, cohort 1, cohort 2, very similar to mavacamten. There was a dramatic reduction in LVOT gradients when you start this medicine, and patients feel a lot better as well. So because of the effect of all these cardiac myosin inhibitors, mavacamten was the first one that already finished their phase 3 trial. The FDA has approved commercial use for mavacamten in 2022, and maybe some people on this are on mavacamten, and they will know the next part of this very, very well. Is that because of the fear of reduction in ejection fraction, which I think is very valid, there are mandatory requirements required to prescribe the drug. And what the requirements are is that not every physician or cardiologist can prescribe the drug. The prescriber has to be REMS certified. Second, there's only a certain amount of pharmacies in the country that can dispense the medication. So if you go to your local shop, pharmacy shop, they might not even have the medicine or not even allowed to prescribe the medicine. And then the patients themselves have to enroll in the program in order to receive the drug. And I'm going to talk about that in a little bit. This is how we are prescribing the drug. This algorithm, you don't have to memorize it. I don't even memorize it because we have this just kind of posted. It's very, very complex. I'm going to try to simplify it in a way from a patient perspective. Is that what should patients expect when they take the drug? This looks like a lot that the patient has to do. But I think I always tell the patients, at least initially, is that we got to go back to the data and realize that cardiac myosin inhibitors work very, very well. They decrease the gradients and they make people feel better. And so what it does require is a motivated patient and a robust team. Because of the fear of the ejection fraction being lowered, these patients need a lot of echocardiograms. In the first year, they need 7, and every year afterwards, they need 4. And that is if they have no dose adjustments. It's a lot of echoes. There's no lie about that. But the idea is that you can catch if the ejection fraction is getting decreased, then you can kind of reduce the drug or stop the drug, and in order to make sure the ejection fraction doesn't go below 50%. The most common symptom when patients start, I feel, is dizziness, and that usually goes away with time. And I've actually used this as an opportunity because a lot of these patients are on beta blockers or calcium channel blockers in addition to the Camzyos that you're starting. I actually use that as an opportunity to decrease the beta blockers and calcium channel blockers, and usually the dizziness goes away. Very important is that mavacamten has a lot of drug-drug interactions. Not a lot, but there are certain ones that we should know about. And so if you're a patient about to be started on mavacamten, it's really important for you to inform your HCM provider about any medications that you start, whether it's another doctor prescribing it or an over-the-counter medicine like Prilosec has a big interaction with mavacamten. And so it's important to know that if you're taking any OTC medicine or prescribed medicine, you let your pharmacy or HCM provider know so they can know how to dose adjust one or the other drug. How do we prescribe cardiac myosin inhibitors? And I will say that this really requires a team and a lot of institutional buy-in. Here at the University of Kansas, we have 4 dedicated HCM physicians. We have multiple nurse practitioners. We have many nurses involved in HCM care because following this algorithm is actually a lot of hard work. You got to make sure the echoes are done at a certain time. You got to make sure the paperwork is done at a certain time. It's very, very difficult. This is a very hard drug to prescribe without a major team. So one person can't do this. And I really highly rely on my nursing team here. They've done a great job in kind of making this an actionable in a machine in order to prescribe Camzyos. And so if you're looking at programs to prescribe this medicine, I would really, look into what is their institutional framework and kind of what's their infrastructure, because not one doctor can do this. It really requires a village, and also requires a dedicated echo lab that can accommodate the 7 echoes that each patient's going to get in the first year and the 4 echoes they're going to get done afterwards. What about non-obstructive HCM? I didn't really talk too much about it because right now there's no proven therapies for this population. But I do want to say is that initial data from mavacamten and aficamten are very, very, hypothesis generating and very, intriguing that there could be a benefit. And so there's 2 ongoing trials right now, Odyssey and Acacia. Odyssey is already completed enrolling, but here at KU we're going to be activated for Acacia soon. So if you're someone in the area that has symptomatic non-obstructive HCM, you don't have a gradient, reach out and see if you could be a candidate for this study, because I think this is the next frontier, is how do we treat these non-obstructive patients. So that my take-home points is that this is the first treatment in hypertrophic cardiomyopathy that is targeted to the underlying mechanism of the disease. I think this is one of the first steps to actually finding a cure in hypertrophic cardiomyopathy. These drugs make patients feel better and function better. It reduces the need for septal reduction therapy, and I'll go and say that patients now can feel that there is a safer alternative or a safe alternative to septal reduction therapy. There's reductions in gradients and biomarkers. There is a reduction in ejection fraction around 5 to 10% in the obstructive population. It does require, again, a motivated patient and a large team to get this done, but it works if everything comes together. And obviously, we still need long-term data. I think the initial data that we've had so far has been very positive. The 120-week data has been very positive. The gradients have maintained low. But what are the implications of chronic suppression? We don't know, and we're learning together. That's the hard part, is that these drugs are relatively new, and as we get more and more experience, we'll learn. But so far, the data has been very positive. That's all I got.
Thank you very much. Do have a couple qualifiers and then a couple questions. So
Yeah.
technically, if you ask the 2 big pharma teams that are in the space of myosin inhibitors today, they will qualify mavacamten as first in class, or first period end, and aficamten is second in class, not next generation.
Okay.
I know it's one of those like wordplay things.
Yeah.
It's the next one. We're just going to call it the next
It's the next one.
And there's a next one after that that's going to be starting a trial soon too, from a company called Edgewise. So the concept of myosin inhibition is really changing the face of managing HCM. So I'm going to tie in Lauren here. Like 25 years ago, myosin inhibitors, did anybody even know what that meant 25 years ago? And what do you see, just kind of looking at where we were and where we are in a quarter century? What do you think?
I think we have come a very, very, very long way in many aspects of the disease. 25 years ago, we weren't using cardiac MRI, or not to any significant extent at all, in HCM or in cardiology overall. We've got better diagnostics, and we've got better therapeutics. I mean, having a drug that was tailored from a basic science standpoint to treat HCM is truly amazing. And, we don't know what we've got with mavacamten, which is the most experience and the longest experience, is a few hundred patients for at most a few years. And, that's when if you're putting a 20-year-old on this drug, if it was me, I'd say, well, so what happens after 30 or 40 or 50 years on this drug? And the answer is we don't know because it's new. And that's one of the reasons why the FDA put it in a tight little box to make sure that we are very careful about what's being done. And the FDA has also mandated a long-term registry of a much larger population of patients so that we have an expanded database. Because there are a very small number of drugs in my 40 plus years in medicine came out, looked good. You give them to 100,000 patients as opposed to, 1,000 patients. And all of a sudden you find out that there are problems that little subset hadn't identified. So we will continue to have a lot to learn. But I am, really impressed by the improvement we've seen in patients who otherwise had their backs to the wall, and they, we were doing the best we could. They were doing the best we could. But it's like, oh my gosh, look at the improvement. I've started several people on mavacamten who are like, leave me alone, I'm doing fine. And I'm saying, no, you've still got a gradient of X, Y, or Z. Do me a favor, try this drug. And they're back in a month going, oh my God, I thought I was doing fine. I feel so much better. Now, guess what? Not everybody has a dramatic response to every drug. This isn't magic. Not everybody tolerates it. Not everybody improves, but it's a huge addition to our arsenal. And I think there's more additions coming down the pike. So it's an exciting time to be in HCM.
I just came back to the office after a meeting here in Jersey with a new name to the HCM space, that there's going to be a new trial coming out in a couple months, and you'll hear more about it, but there are going to be more options than fewer. And I really put this out as a call to action to the entire community. There are drugs that need trials, and we are people who need answers. We're going to need a lot of people to step up and participate in the clinical trials. And this is a good problem to have, people. It's a good problem to have. And the problem is going to be trial fatigue. We went from nothing at all, nobody paying attention, to everybody thinking we're really cool and they want to help us. This is all good news for us, but it means that you, the patients who are spending time sitting at home with your families, listening to webinars about your disease, which is not exactly how most everybody spends their nights, we're going to have to get you involved in clinical trials, and you're going to have to keep an open mind and at least have conversations with site coordinators, understand the time commitment, what the medicines are, how they can potentially help you, and why it's important for us to learn how these drugs might work in our community. So myosin inhibitors, yes. Cardioenergetics, different concept. Embryo is going to be presenting their data at ACC, and we did a lot of recruiting for that clinical trial. It was a beginning, middle, and end. It's over. But there are going to be other drugs in other classes, SGLT1, SGLT2, in HCM. These things are coming. So everybody keep your little home researcher hats on and be part of these solutions and be part of discovery. And we know it's time, and we know there's a little risk. think about it, talk about it, and please have the conversations. We wouldn't have gotten the myosin inhibitor to the finish line if we didn't all work as a community together. And we're going to continue to learn more about them. And it's a good thing. It's a good time to have a bad disease. If you listen to my podcast, you hear me say that a lot. Okay, we have a question from the community. Can patients who have had septal reduction therapy also benefit from a myosin inhibitor?
Yeah, the answer is yes. If they're obstructive, we have they can. If they're non-obstructive, right now they have to go into trial.
And there's Odyssey is now closed. That's the BMS trial in mavacamten, and Acacia in non-obstructed HCM on aficamten. That trial is open in many spots. And if you're looking for a site, give us a call. We'll help you get connected. Okay, so we answered that one live. And we are going to go on now to talk about invasive approaches to managing obstruction. The topics not everybody likes to talk about because there's knives involved in this one. And I am going to brutalize this lovely woman's name yet again, but I'm going to try with my cheat sheet. And
You got it. You got it.
Do I?
Yes.
Paola? No.
Close.
Paola.
There you go. You
Here we
got
go.
it.
I got it. I'm sorry.
No, you're
I'm terrible
good.
with names.
All right. Let me see if I can get back to where I need to go. Okay.
There you are.
So my name is Dr. Roldan. I'm one of the heart failure transplant cardiologists here at KU. I also am one of the hypertrophic cardiomyopathy physicians. And I'll be talking about septal reduction therapy. Let's see. All right. And so I have nothing to disclose. I did want to give a special thanks to Dr. Wiley. He is our interventional cardiologist who has the expertise in alcohol septal ablation. And then Dr. Muehlbach, who is our CT surgeon at KU, who has a expertise in septal reduction therapy. These are our objectives. So we're going to talk about the indications of septal reduction therapy, as well as the imaging modalities that we use to aid our decision. And then we will dive into kind of the separate septal reduction therapy options, which include surgical septal myectomy, as well as alcohol septal ablation. And as we're talking about them, we'll review kind of the procedure, the procedure, the appropriate candidates, as well as the possible complications. In regards to indications, so there's certain criteria that we think about that are appropriate candidates for septal reduction therapy. And I broke it into 3 sections. And so as Dr. Shah just kind of beautifully explained, if patients are on optimal max tolerated medical therapy, so meaning beta blockers, calcium channel blockers, now cardiac myosin inhibitors, if these symptoms still persist that interfere with everyday activity or quality of life, and these symptoms being severe shortness of breath, chest pain, syncope or near syncope that are occurring at rest or with minimal activity, these may be patients that might be appropriate for septal reduction therapy. So thinking about hemodynamic criteria, so there needs to be an LVOT gradient at rest, or with a physiological provocation of greater than 50 millimeters per mercury due to septal hypertrophy with or without systolic anterior motion of the mitral valve. And so this image on the top is showing a hypertrophic cardiomyopathy patient. It's a 2D Doppler view. And as you can see here, I'm going to see if I can touch my mouse without it moving the slide. If you see here, here's the intraventricular septum, which is very thick, and the left ventricular posterior wall, which is also thick. And here, this black area is the left ventricular cavity, which is very small in this patient due to their hypertrophic cardiomyopathy. And here is the mitral valve leaflet right here. And abnormally, the anterior mitral valve leaflet is moving towards the septum during systole, which can result in LVOT obstruction as well as mitral regurgitation. And then the anatomic criteria that we think about is that there has to be sufficient anterior septal thickness And talking to Dr. Wiley and Dr. Muehlbach, that is greater than 1.7 to greater than 2 centimeters in order to perform the procedure safely and effectively. Again, that criteria of 1.7 to 2 centimeters may differ depending on the operator. And the patients that may benefit the most from this procedure are those in the the sigmoidal HCM patients, which is this type of HCM, or the reverse curve HCM. But again, typically the sigmoidal HCM patients are the ones anatomically that might fit the best in regards to septal reduction therapy. So in kind of summary of that criteria that we talked about, the guidelines would say that ineligible patients with obstructive HCM, meaning an LVOT gradient than 50 at rest or with provocation, who remain severely symptomatic with shortness of breath, chest pain, syncope, or near syncope, despite optimal medical therapy, septal reduction therapy can be recommended for relieving LVOT obstruction. I think the other important thing that they highlight in their guidelines is that when septal reduction therapy is indicated, the procedure itself should be performed at experienced HCM centers with demonstrated excellence in clinical outcomes for these procedures. And this is a picture taken from the HCMA website, where it shows locations across the United States that are considered HCM centers of excellence. And as you can see here, University of Kansas Medical Center is considered one of those centers, again, thanks to the foundation of Dr. Barenbaum, Dr. Wiley, and Dr. Muehlbach. The other indications that might be used for septal reduction therapy is in patients who have obstructive HCM. Earlier septal reduction therapy might be reasonable in the presence of additional clinical factors. So in a patient who has severe and progressive post-capillary pulmonary hypertension or elevated pulmonary pressures due to the LVOT obstruction or the associated mitral regurgitation related to systolic anterior motion. Additionally, if a patient has left atrial enlargement with greater than 1 episode of symptomatic atrial fibrillation, and then in children and young adults where they have a very high resting LVOT gradient greater than 100 millimeters of mercury. The guidelines also state that for patients with obstructive HCM who are asymptomatic, meaning no symptoms, and have normal exercise capacity, septal reduction therapy is not recommended and is considered harmful. So in regards to things that we think about for imaging modalities that might help aid us in regards to thinking if someone is a septal reduction therapy candidate, our baseline foundation is our transthoracic echocardiogram as well as transesophageal echocardiogram. And again, that helps us define the phenotype of this HCM, as well as the thickness of the intraventricular septum, as well as the degree of mitral regurgitation and perhaps the etiology of the mitral regurgitation. And then Dr. Rosamond's, did a wonderful job talking about cardiac MRI, but that can also be used to assess the extent as well as the distribution of hypertrophy, kind of in a more granular way, as well as the myocardial fibrosis. And then in regards to additional imaging, so an invasive coronary angiogram, which is seen here, can be used, or a CT coronary angiogram or angiography can be used to evaluate if someone has coronary artery disease, as well as to assess for septal perforators. And so seen here, this is a catheter that's engaging the left coronary system. And here you see that contrast is filling the left circumflex artery. And then here you see the left anterior descending artery going along this route. And then these little contrast-filled arteries are the septal perforators, and these are the arteries that perfuse the intraventricular septum. And so this is to assess if someone has appropriate septal perforators for alcohol septal ablation. So when we talk about patients, we meet in a multidisciplinary manner. And that means we've got our HCM cardiologist, our interventional cardiologist, Dr. Wiley, and then our CT surgeon, Dr. Muehlbach, where we sit down and we talk about which septal reduction therapy option might be the most appropriate for patients. And a lot of that goes into discussion about patients' comorbidities, the appropriate type of anatomy that they have, if they have appropriate septal perforators, what other underlying bundle branch blocks that they might have. So it's a very, in-depth conversation, but to kind of break it into kind of two buckets. Alcohol septal ablation is recommended for patients if surgery is contraindicated or the risk is considered unacceptable because of serious comorbidities or advanced age. And again, they have to have appropriate septal perforators available. And then surgical myectomy is recommended for patients who are eligible for surgery with or without conditions that also might require surgical treatment. So for example, that might be someone who's got anomalous papillary muscle, an elongated anterior mitral valve leaflet, or someone who truly has intrinsic mitral valve disease or aortic valve disease. And then again, the coronary angiogram might highlight that someone also has multivessel coronary artery disease that might benefit from bypass surgery. So moving on to septal myectomy, kind of just a brief history of the procedure. It was first performed in 1958 by Dr. William Cleland in the UK, and then was later termed the Morrow procedure after Dr. Andrew Morrow, who's depicted here, who just looks like the happiest surgeon ever, in 1975. And that's after he published his experience of 83 patients. And I guess I should also highlight that this gentleman's drinking coffee as well as smoking. But again, this was in the 1970s, and that was a little bit more common. Two approaches that physicians take is the transaortic approach, which is the approach that Dr. Muehlbach takes, and I would say a majority of centers also use. And then there's a transapical approach. I'll talk about the transaortic approach when I talk about the procedure itself. So after a patient has the septal myectomy, what happens is they get placed on a cardiopulmonary bypass, and then the aorta is opened, and then the surgeons will try to visualize the aortic valve leaflets, and here they are separated apart so that the surgeon can see the septum. And here, once they feel like they've got an adequate visualization of the septum, they will use their tools to excise the portion that needs to be eliminated. And then with the use of transesophageal echocardiogram, they can see what the gradients look like to see that there's a significant gradient reduction, as well as to visualize, the portion of myectomy that they're excising. But then they also get to see the degree of mitral regurgitation as well as systolic anterior motion and determine whether or not someone might need a mitral valve repair or mitral valve replacement. The complications that can occur during septal myectomy. So the most common is the left bundle branch block, followed by complete heart block requiring a permanent pacemaker. And here's a depiction of what that might look like. So as they're excising, a portion of the septal myectomy, the left bundle might get hit and cause a left bundle branch block, or both of these portions or the AV node may get hit, causing complete heart block. And then, as with any other surgery, or cardiac thoracic surgery, I should say, atrial tachyarrhythmias and then ventricular tachyarrhythmias may occur. And then if a portion of the septum is damaged, or if there's too much of the septum damaged, or sorry, excised, it can cause a ventricular septal defect. And that's a very rare cause, but something to discuss. Cardiac tamponade, meaning when blood fills the pericardium, which is blood filling the pericardial sac that surrounds the heart muscle, that can also cause something called cardiac tamponade. And then non-cardiac related complications, so any complications from anesthesia, infection, a vascular injury, and then bleeding and death. Alcohol septal ablation. So this actually was first introduced, sorry, this is little technology difficulties is what we've been having this evening. So alcohol septal ablation, so it was actually first introduced by the Bighearted brothers, and they weren't trying to do a septal ablation. What they were trying to do is a ventricular arrhythmia ablation. But that's kind of first what sparked this idea of alcohol septal ablation. But it was first performed for septal reduction in 1994 by German physicians led by Dr. Gietzen, and then English physician led by Dr. Sigwart. And they actually published pretty short one published in April and one published in June. So very much they were aligned in regards to when they were doing this procedure. And then the field of alcohol septal ablation really changed with the introduction of myocardial contrast echocardiography. And that is where you get to see the perfusion area of the septal branch to the area that a interventionalist wants to target for septal ablation. And so that's been, I think, monumental in regards to finding the accuracy of the location, as well as trying to deliver less alcohol to cause less complications. So the procedure itself, so once a interventionalist gets access into the common femoral artery, a catheter is taken to the coronary system. The coronary artery is engaged, and a catheter with a balloon at the tip is delivered into the septal perforator. Once it's engaged into the septal perforator, the balloon is inflated, and then 1.5 to 2.5 cc's of alcohol is delivered to that septal area. And again, transesophageal echocardiogram is used to assess this during the procedure. So complications, the most common is right bundle branch block. And again, complete heart block requiring permanent pacemaker. Those are the most common complications. Atrial tachyarrhythmias, ventricular tachyarrhythmias can also occur. And then a coronary artery injury as they're engaging the coronary artery is possible. And then cardiac tamponade, as we talked about before. And then some non-cardiac related complications. So complications from anesthesia, infection, a vascular injury at the site where the catheter is accessed, and then death. So looking at, if you had to compare alcohol septal ablation versus septal myectomy, it'd be great if we had a randomized controlled trial that looks at patients that were randomized to alcohol septal ablation versus septal myectomy. And unfortunately, we don't have that, and I don't know necessarily if we will ever have that type of trial. But what we do has we have 6 trials that are outlined here that were summarized in this table by Dr. Liegert in 2017, and it looked at trials that had a mean follow-up of 3.5 years. And to kind of summarize this table, the things that they looked at were the need for permanent pacemaker implant, the need for re-intervention, meaning a patient has to go back for alcohol septal ablation or for septal myectomy, all-cause mortality, as well as aborted sudden cardiac death. And to kind of summarize what the 6 kind of long-term trials show is that there is higher incidence for permanent pacemaker implant in the alcohol septal ablation group compared to the septal myectomy group. And then there is also a need for re-intervention in the alcohol septal ablation group than the septal myectomy group. But looking at all-cause mortality as well as aborted sudden cardiac death, the risk of in both of those groups was low and very similar, and non-significant p-values. So take-home points. So septal reduction therapy is recommended in patients with resting or provoked LVOT gradient of greater than 50, who have significant symptoms at rest or with minimal activity despite max tolerated medical therapy. Septal reduction therapy should be performed at HCM centers of excellence, where again, both procedures are available and both have been done at decent volumes. And then a multidisciplinary team approach is used to determine the best septal reduction therapy option for each patient. And that weighs in a ton of factors, including kind of the type of HCM, the appropriate septal perforators, existing left bundle branch or right bundle branch block, etc. And then long-term follow-up studies would suggest that sudden cardiac death and mortality rates were very similarly low in both groups, but the rate of reintervention and pacemaker implantation is higher in the alcohol septal ablation population compared to the septal myectomy population. I do think, though, that with advances in technology, imaging technology, again, that this may play a role in how alcohol septal ablation may kind of decrease, pacemaker implantations, but as well as reinterventions. So yeah, I think that is all I have. Again, sorry for some of the technology difficulties with advancing.
I am just convinced that the internet just doesn't like me.
I think so too.
It happens. Thank you so
Yeah.
much for a very comprehensive overview. And like, I'm listening, I'm like, oh yeah, I forgot about that. I always remember that back in the day. And, in the late 90s, everybody thought that alcohol septal ablation was going to put an end to the need for surgery.
Yeah.
Didn't need to worry about obstruction anymore. We had this figured out.
Yeah.
And before alcohol ablation, it was dual chamber pacing for
Mhm.
obstruction. And we're always trying to chase that obstruction. It's just so nice that we're getting down to core mechanistic action
Mhm.
and using that in concert with great surgeons, great precision medicine approaches. And we really are a model disease for the importance of collaborative, multidisciplinary teams
Mhm.
because it's really getting more tricky to figure out what's right for what person.
Yeah.
So
Yeah.
that's great. So far, we don't have any questions, so we're going to move on. I'm sure they'll throw
Okay.
them at the end of the night.
I put everyone to sleep.
Oh no, they're awake. They're here. So they don't know that one of the things that we actually have is, part of the Zoom technology now kind of lets you know when people are distracted, when they're
Mhm.
actually watching the screen or when they move away. We have very good stick-to-itiveness numbers. And they watch, they're interested. Okay, so we are going to move over to Farah and we're going to talk a little bit about the role of genetics, which is a critically important topic today. We are in a day that gene therapy has now occurred twice in hypertrophic cardiomyopathy, third one coming soon, we believe. And how are we going to figure out what genes we're targeting and where are we going and where have we been? Farah,
Thank
take
you.
us down this path.
Thank you, Lisa. Can you hear me okay?
We can hear you, but you're not in present mode yet. There you are.
Yeah.
You are perfect.
Thank you. So again, my name is Farah Amori. I'm a genetic counselor in the cardiology department at the University of Kansas Health System. And today I will be reviewing the genetics of HCM. I will be reviewing some background information on genes and genetics, also the role of a genetic counselor in the cardiology clinic, and the genetics of HCM, and also end off with a case example. So what are genes? I always like to begin by showing my patients this visual so that they have a better understanding of what genes are before I discuss genetic testing options or genetic results. So genes are instructions in our body that do different things that are important for how our body grows. And they are found inside of our cells. And our genetic information is also known as our DNA. Within our DNA, we have specific segments that we call genes. And like I said, we have thousands of genes that do different things. And some of these genes are important for the heart function. And so that's what we would be looking at when we do genetic testing, is looking at specific genes that are related to the heart. And the genes are important because they produce these proteins, and that's what really our body uses up to do its different functions. So, as a genetic counselor, we are healthcare providers who have a master's or a doctoral degree and have training in medical genetics and psychosocial counseling and specialized in cardiovascular genetics. So when you go to see a genetic counselor in the cardiology clinic, some of the things that we will do is discuss detailed patient and family medical histories, assess for heritable cardiovascular disease, make recommendations for family screening. And also some of these discussions might be difficult or challenging, so we can provide with psychosocial support and resources so you are able to discuss these things with your family members. And of course, discuss genetic testing recommendations or genetic testing results. Current guidelines do recommend genetic testing and counseling for all patients with cardiomyopathy. So the genetics of HCM, as I'm sure you know by now, HCM is the most common genetic cardiomyopathy, affecting 1 in 500 individuals. And so when we do genetic testing for HCM, and maybe there isn't a family history that we are aware of, we can pick up a genetic diagnosis in up to 40% of these patients. When there is a family history of HCM, and with the patient, that percentage increases to 60%. And most of the genes that are associated with HCM are important for making certain proteins that are called sarcomeric proteins, and these are involved with the contraction of the heart muscle. So when we do pick up a genetic diagnosis with the genes involved, most of the time, the way that they are inherited is called autosomal dominant pattern of inheritance. There are other forms of inheritance, and I'll review just the most common ones. So that's important to know in order to know how a genetic condition is being passed along in the family. And it's also important to know that when we do pick up a genetic mutation, not everyone will show symptoms of HCM. And even within the same family, the symptoms might be variable. And these are, common phenomena in genetics that we call reduced penetrance and variable expressivity. So in terms of inheritance patterns that we can see, like I had mentioned before, most of the time when we do pick up a genetic mutation for HCM, it is inherited in a dominant manner. So we have 2 copies of every gene. We get one from our mom, one from our dad. And so this person has a mutation in one of their 2 copies, and that is enough to show symptoms of HCM. When they go on to have children of their own, they have a 50% chance of passing it along to each of their children. Whereas with recessive inheritance, you need to have 2 genetic mutations in order to show symptoms. So for this example here, this child is affected because they have 2 genetic mutations, and they inherited each mutation from one of their parents. But their parents have only 1 mutation, and therefore they are carriers. Most of the time, carriers do not show symptoms of a genetic condition. If they do, it's usually more mild or not showing any symptoms at all. So in terms of the genes involved, there are many genes that are related to hypertrophic cardiomyopathy. Just to name a few are on this table. I'm not going to go over all of them, but the most common causes of genetic hypertrophic cardiomyopathy are these first 2, the MYH7 gene and the MYBPC3 gene. And they can make up to 70% of cases of genetic hypertrophic cardiomyopathy. The frequencies may vary a little bit depending on the resource and the papers that we're using. And it's important to note that knowing exactly where a genetic change is found within that gene is important because it helps us know if other people have been reported with it and what kinds of symptoms they developed. So how can we get genetic testing for hypertrophic cardiomyopathy? There are many different ways to go about doing this. We can either do targeted genetic testing, which would focus on genes that are associated with HCM, and that would include about 30 to 50 plus genes. There are many different labs that offer genetic testing, and so depending on which lab you're using, the number of genes would differ. Each lab has their own criteria for determining which genes are involved, and that's based off of their internal data and some of the research studies. We could also do comprehensive genetic testing, which checks for a panel of genes that are associated with cardiomyopathies and along with arrhythmias. So it's not only focusing on HCM, it's focusing on other types of cardiomyopathies along with arrhythmias, and those gene panels are bigger and can range from 100 to 200 plus genes. And current research has shown that more expanded or comprehensive genetic testing has a higher diagnostic yield or higher chance of picking up genetic mutations, because some of them might be missed on the smaller panels. And as an institution at the University of Kansas, we are committed to ordering more comprehensive genetic testing for our patients. So how do you find a genetic counselor? You can ask your provider if your institution has a cardiovascular genetic counselor to coordinate family testing or genetic testing for yourself. You can also find some information at the National Society of Genetic Counselors on how to find a genetic counselor near you. So the case example that I'm presenting today is a 31-year-old male who underwent cardiovascular screening because of his mother's history of hypertrophic cardiomyopathy. He has otherwise been healthy and did not have any other medical concerns, but when he did the screening echo, it showed basal septal hypertrophy. So the cardiologist recommended genetic testing and counseling. When I saw the patient, I gathered a detailed medical and family history. So this is how the family history looks like in what we call a pedigree or a family tree. Just to orient you with some of these figures here, we have circles and squares. Squares are males and circles are females. The ones that are shaded are the ones who have a known diagnosis of hypertrophic cardiomyopathy. And the ones that are crossed are the ones who have passed away. So I named my patient John Smith. This is not his real name. He's 31 and he has hypertrophic cardiomyopathy. And he was diagnosed in 2023. His mother also has HCM, diagnosed at 54. His grandmother also reportedly has HCM, and she passed away at 68. So as I said, the cardiologist recommended genetic testing for this patient. And the type of genetic testing that was done is a comprehensive genetic test, and it looks at genes related to cardiomyopathies and arrhythmias. And the testing came back positive, and that just means that we did identify a pathogenic or a harmful mutation that explains his own history of HCM along with the family history. And the report will give us information on where exactly the mutation was found. So they're giving us the exact location so we know when other people want or when other family members want to get genetic testing, what exactly we're looking at. And also, it provides us with information on whether other people have been reported with this specific mutation. The rest of the report goes over some of the logistics and the genes that they looked at. Again, they looked at a lot of genes, 92 of them. Some of them are related to cardiomyopathies and others are related to arrhythmias. And it also goes through the exact genetic mutation that was found in the patient, and it tells us that this variant has been detected in other people with HCM. So what are the implications of knowing these genetic results? The most common question I get is reproductive planning and what that means for the future. So in this patient's case, he has a 50% chance of passing it along with each pregnancy. And so there are options for genetic testing prior to becoming pregnant or during pregnancy. And so there's an option for something called pre-implantation genetic testing, and that has to be done through IVF, where they can take the embryos and do genetic testing on them before implanting them. The other options would be genetic testing during the pregnancy or after the baby is born. It's also important that at-risk family members or first-degree relatives seek clinical evaluation and be offered genetic testing so that they can get screening and early detection of the cardiomyopathy or arrhythmia. And many of the speakers today have talked about research opportunities. So there's always opportunities for research or being included in clinical trials. And so one website that we often go to check those is clinicaltrials.gov. So I hope this was helpful, and please let me know if you have any questions about anything that I've discussed today. Thank you.
There is a question, and there's also the poll results, which I think is well timed that I put it on at the end. This day has just been a technological challenge for many of us. So the question to you is, can HCM skip a generation?
That's a great question. So, when I talked about variable expressivity and reduced penetrance, so that's something that comes up with with a lot of genetic conditions where not everyone will develop symptoms. So, you know, even though we do genetic testing on an individual and maybe their children, they might not develop symptoms, but it doesn't mean necessarily that their children will not develop symptoms. So it's still important for the person who has a genetic mutation to get genetic testing and screening.
So I will bring up the difficulty in the genetic testing realm right now for many people around the country, and that is the company Invitae is having some financial and operational issues, not a problem with technology or interpretation of results. The problem is really, honestly, most of the genetic testing companies have not been able to operationalize to a degree in which they are profitable and self-sustainable. So they're going through a reorganization. I have talked to a number of people at Invitae. They will probably go under another name soon, but all your data will be shifted. And as soon as we figure out what that's going to look like, we'll let you know. So your data is safe. It's a really good platform. It's a reorg. It's a business problem, not a technology problem. So it's just that's a little bit of stress because we have lost a couple of providers in this area. And one of the things HCMA hopes to be able to do for our families in the future is give them a parking spot for all of their HCM related test results. So if they move or a company goes out of business and they're not sure where something is, you'll have a home here. You're going to start hearing home a lot from me. So we're going to be your heart home. We're just going to be your place to hang. Okay, we have another question. Who in my family should get tested? Siblings, nieces, nephews? So we need a starting point to be able to determine who needs to be tested, Kelly. So I'm going to let our genetic counselor explain that process one more time.
Yeah. So we usually start with first degree relatives. So that would be for you, Kelly. Was it Kelly is the name of the person who asked? It would be your children and your siblings, along with your parents. So that would be the most informative to start with testing first degree relatives. And then from there, if an individual tests positive, then their children would need to be tested.
Fantastic. I think that helps. I like to think of the up, over, and down model.
Right,
Up to your
exactly.
parents, over to your siblings, down to your kids.
Your children,
Repeat when necessary.
exactly.
Wash, rinse, repeat. Okay, we're going to take a quick second here before we hear from Lauren, and I'm going to share the results of our poll. So we all know who we're talking to when we get to the Q&A portion. So we have the majority coming from the Midwest today, but we do have some Canadians, no other countries other than Canada and US today. Northeast, Southeast, Southwest, West, and Midwest definitely wins today. So what is your relationship to HCM? 68% are patients, 14% are both patient and family member, 11% are family members, 3% are medical providers, 3% are industry, and there's my ever favorite, just curious. We add that in just cuz. So just curious, if you're still with us, your job now is to go into the chat and tell us why you're curious and have you learned anything and how you found out about us. I'm always curious about the curious. Okay. Have you or your family members had any of the following? Check all that apply. diagnosed within the last 2 years. We know that's one of the most challenging times with HCM. 24% are there. 62% are on medication. 35% have ICDs. 24% have had a septal reduction therapy. 43% are having AFib. We know that is a real challenge for this community. 11% of us have lost family members. 54% have had genetic testing. Ooh, that's a good number. I've been advised to consider an ICD, but I haven't done it yet, 3%. I've been advised to consider septal reduction therapy, 11%. So we have some shoppers among us today collecting information to try to figure out what's next. Okay. Are you considering a new device or medication at this time? 16% are definitely shopping and learning, and 84% not yet. Are you being seen at a center of excellence? Are you currently being seen at this center of excellence? 62% yes, 35% no, 3 aren't sure. I'm sorry, that's just general center of excellence. How many of these are your patients? 39% have been seen at KU, the rest have not, and 29% are not being currently seen at a center of excellence. So we have a potpourri, but this is a pretty typical breakdown for us, especially when it comes to the experience section in question 3. There's a little AFib heavy tonight, so maybe Dr. Birnbaum can talk a little bit about AFib at the wrap up. Okay, so we are going to get on to talk about research a little bit. And without further ado, Lauren, the stage is yours.
Well, we'll see if I can do better than last time.
We lost you last time. Just don't
Yeah,
hit that red button in the corner.
No, my internet kicked me out.
Oh, that's painful. That happened
Yes,
to me once.
I got kicked off altogether. So I think that you have met most of the team. Jared Kvapel didn't get tagged to speak this evening. I suspect he's on somewhere. Jared is a general cardiologist. Mark Wiley used to play a bigger clinical role in our HCM program. But he's now running our group of 50 some cardiologists and 50 more mid-level providers. And so he doesn't do as much clinical care as he did, but he is doing our our alcohol septal ablation. And as I said, he's been doing that about 15 years. Before he started doing them, we sent him to Germany to work with Hubert Segeweiss, who has done thousands of these. He learned all about selection and how to do this properly. He came back. We collected a group of patients. Dr. Segeweiss was coming to this country and spent several days in Kansas City proctoring him in our labs to do these cases. And I think this is representative of the careful, thoughtful way that we like to do things, and not just jump in and say, I got a catheter and I know where the septals are. I'm gonna, start doing alcohol septal ablation. Dr. Muehlbach did an extra year of fellowship at the Cleveland Clinic, which is one of the major centers for myectomy in this country. So he got a significant experience there. John Fritzlin is one of our cardiology fellows. He's a little over halfway done, has 15 months to go. He is going to be joining us and joining the HCM team. He's going to spend some time outside of KU to see how other centers of excellence work. We have 2 advanced practice providers, 2 genetic counselors, and several nurses. A shout out to John, who I had very vanilla black and white slides. He turned them into colorful slides and added all the pictures of everybody. That is way beyond my technical skills. I probably wouldn't be on here if John hadn't helped me figure out how to get the slides on my desktop. In terms of research, the Odyssey trial for non-obstructive HCM has closed because it's fully enrolled. The average clinical trial, they say, well, we'd like to enroll our patients in a year, and it takes them 3. Trials never enroll faster than the sponsors and investigators are hoping, except Odyssey, which just blew through enrollment, which I think is a real testimony to patients with HCM, to the HCMA, which has really advocated and worked with patients to help get them to centers of excellence who are in the trial. So I think it's amazing that trial went so fast. It'll be a while before we get data from it. But I mean, the non-obstructive HCM patients are ones that we have limited tools to help, and it's really important to figure out new tools to help them. Discover is the FDA mandated registry, long-term follow-up of HCM patients, both with and without mavacamten, because you have to have something to compare to. And I think that's going to be a very, very important database over time. Again, it will be a number of years before data starts coming out of that. This MYK 224 is a phase 2 trial, sort of a second generation mavacamten from or maybe not second generation, but an additional myosin inhibitor from Bristol Myers, who came out with mavacamten. And we've actually wrapped up enrollment in that one. That was just a very small number of patients, really to understand the drug better. We are moving quickly to begin enrolling patients in Acacia, which will be aficamten and non-obstructive HCM, because we've got a lot of non-obstructive patients that we didn't get into Odyssey, and we are looking for those additional tools to help them. If you are interested in becoming a patient, those are contact numbers. And, I do think that, what I learned from Lisa 20 some years ago when we first met is that the average cardiologist sees 4 or 5 patients with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy comes in a lot of different shapes and sizes and flavors. And if you're seeing 4 or 5 patients with hypertrophic cardiomyopathy, it's hard to be really good at what you're doing. We have about 702 patients apparently at KU now with HCM, divided between 4 of us primarily. So that's 150 to 200 patients apiece. And that gives you a much better perspective on how to take care of patients with HCM. One other comment I want to make is that when we do things like this, we tend to talk about the bad parts of the disease and bad outcomes. I think it's important to stress that most patients with HCM do very well, live long lives, and die of something else. We are all going to die, and by and large, we want it to be later. But again, you get into this type of conference and you say, well, gosh, everybody with HCM gets into big trouble and it's a terrible disease. It can be a bad disease, but for most patients, it is very manageable. And we are making significant strides in making it more manageable. So, Lisa, back to you.
We have some questions and we have some comments as we wrap up this evening. So a dear friend to both of us, Fida, is chiming in. I'm going to first share that she says she's very lucky to have a cardiologist like Dr. Birnbaum. And I would agree because her and her family have had some real challenges with their HCM. I'm not going to ask her question exactly as written because it's very specific, but Peta, I'm going to kind of bring this a little bit more globally. In the event, here, we'll stop screen sharing. We'll do the Brady Bunch view for now. In the event that there are multiple individuals in a family with hypertrophic cardiomyopathy, are we expecting every one of them to have the exact same progression, symptoms, side effects, or is there variability within families? And can anybody ever really just say, it's just going to be a little thing and I can relax now? How do you do surveillance long-term in complicated families?
I think there are a very small number of patients where the disease tends to be really bad and to manifest very extensively. I think that, back in the 90s, I had a woman who was in her 80s who had HCM, who had 3 daughters, and this was before genetic testing, and we just didn't know then what we know now. 3 daughters, they were all very conscientious. They got screening echoes. They didn't have anything. Nobody worried about the kids because apparently, the grandkids, because apparently none of the kids had an issue. And then a grandson, unfortunately, very unfortunately, drops dead jogging. I didn't understand that well enough in the early 90s, and I don't think most people did. I don't know that anybody did. We see a lot of, I have families where there's 3 people that are gene positive, and one fully manifest HCM at age 16, 2 others with the same gene, and at 25 years old, they look completely normal. There's work that's been done to try and figure out, is there anything we can do to help keep an HCM gene from triggering? One of those questions ultimately is going to be, if you put somebody on a myosin inhibitor when they're young and maybe just give them a smidge of myosin inhibitor for 50 years, they'll never manifest. But it's important to do genetic testing, because if there's somebody in the family who's gene positive and other people and somebody else in the family is gene negative, they don't have to worry about HCM, and neither do their kids or grandkids, etc. If you're in a family that's gene negative, I think you need to screen the heck out of the generations. That would be my recommendation. I also know that oftentimes, I've got HCM, I've got 4 kids, 3 have been genetic tested, one of them won't go near anything, and that's often the case. And, but you try and chip away at folks over the years and convince them to, get inside the tent and be proactive.
I think we're getting to a better stage of being able to be more persuasive in that conversation, because 25 years ago, it was get a big box in your chest that doesn't really fit there yet, but we can jam it in there to protect you, or we could cut your chest open and take a piece of your muscle out, or we could give you a heart attack. Like, the options just really didn't sound very appealing. And a lot of people were like, you know what, I think I'll just wait for something better. Well, guess what? Better showed up. And we have a lot of better options, and they're even getting more precise and better. We hoped, I can remember 15, 20 years ago going to personalized medicine conferences, trying to figure out what actual personalized medicine was. We're here. We're using our genetic information and a toolbox full of really interesting options, whether they be devices, drugs, procedures, surgeries. We have more and more to pick out of the box. And it doesn't have to start with, let's just throw you on 200 milligrams of a beta blocker and let you be comatose forever. We have more precise medications, so you don't have to worry about some of the side effects. So again, good time to have bad disease, but bad disease doesn't have to be bad outcomes. So we're all getting smarter together. We got a bigger boat. We got more people on the boat. We got more ports for the boat. And we're building a community that has deeper understanding. And I showed you a film earlier of a man playing basketball professionally with HCM. That was not going to really happen 25 years ago. And I'll take a stab at the health equity line here. If you said 30 years ago, hypertrophic cardiomyopathy in basketball, you thought of Hank Gathers and Reggie Lewis. And we're not there anymore. Why? We're better at risk assessment. Why? We're better at treatments. Why? We're better at bystander CPR, AED, secondary support. God forbid all of the other safety plans failed. We have a better layout. All you have to do, and I won't show these films, but if somebody wants to go look for them, there are films of Hank Gathers dying on a basketball court. His coach grabs him, cradles him. Nobody starts CPR. Nobody grabs an AED. It was 1990. There weren't any. And everybody just sat and watched this poor man die. And nobody did anything because there wasn't much really to do at that time. You flash forward 23 or 33 years to DeMar, NFL game, cardiac arrest in front of people, chest blow. He does not have hypertrophic cardiomyopathy. Don't be starting rumors now. So he goes down. There's hands on him in seconds. There's good compressions being done. The AED is brought in. There might have been a minute or so delay more than they told you about up front, but the defibrillator went on, shocked him. He's back playing football. That's a difference of 33 years. That's a difference of people like us talking about things like this and saying, how do we move the needle? You don't always see the needle when it's moving. But when you look at that difference, the world has changed. It's not bad to get diagnosed with HCM. It doesn't have to limit you. There is a question in the Q&A here about life insurance and genetics. And unfortunately, the Genetic Information Non-Discrimination Act does not provide protection for life insurance purchase, and your medical history and your family may preclude your children as well. So you may want to do genetic testing to prove that the child does not have the gene in some circumstances. But we do recommend that everybody with HCM who's considering gene testing make sure that they're optimizing their life insurance as best as possible. And typically that's going to come through employer organizations, fraternal orders, group policies. That's where you're likely going to amass the most life insurance with HCM pre-genetic testing or after diagnosis of HCM. So always, this is the former human resource manager speaking now, maximize your employer benefits for life insurance if you have hypertrophic cardiomyopathy. It's probably the only place you're going to get access to it. So I answered that. Farah, did you want to add anything to that?
That was beautiful.
Thank you. I've done this before, and I helped get Gina passed in 2008. So I better know that.
That's awesome. Yep.
Okay. If a child of an HCM patient refuses to get genetic testing, would the children of that particular child be allowed to get testing? Allowed is a really weird word here. Allowed means more than will the insurance company pay for it? Anybody can go get screened. Will the insurance company pay for it? In all likelihood, yes, in my experience. Lauren, what would you say in that situation if anybody else wants to pop in?
I always like to start genetic testing with somebody that we know has disease and see if they're positive or negative. Because if your brother has HCM and he's gene negative, you're getting tested and knowing that you're gene negative doesn't mean anything. It's not reassuring. So it's always better to start with somebody who's known positive, known disease in the family and get their genetic result. But yeah, I mean, if grandma or grandpa is gene positive and mom won't get tested, but somehow she'll allow the kids to get tested, or dad takes them unbeknownst,
Yeah.
whatever. Get them tested. Yes. It's a lot cheaper and more definitive to do one genetic test than it is to do screening echoes even once, let alone every 2 years or 5 years, depending on the age of the patient.
There are a lot of different family dynamics out there, and there are people who have different levels of trust for the healthcare system in general. This person may change their mind with a little bit of education. One of the pieces that we're going to be working on in the next couple of months is our HCM Nest program, which provides educational tools to patients after they've gone through their intake and navigation call with us. We're going to be adding an element where they can push information through email to family members. Here's my genetic information. Here's how you can get genetic testing. Here's a center near you. They're going to be able to communicate in a different way. And maybe if there's a little bit of a buffer between the family member and the health imperative and the communication, maybe we can play that buffer role a little bit better in a more meaningful way. So we're always looking for ideas. Anybody have any brilliant ones, please share them with us. But it's really important that our families listen. Only about 15% of our population has been diagnosed because of a family screening. And it should be way higher than that, because it's awkward to talk to your family about these things. They don't want the information about their heart from their little sister. They don't want that. They want it from a cardiologist, or they want it from an organization. So maybe we can play that buffer line. Any brilliant concepts here, Farah, that I can share with them?
Yeah, just to add, that's something that we always discuss with family members. When I was discussing psychosocial support, again, talking about those challenging family dynamics and how to disclose these kinds of results with family members. So oftentimes I provide them with a family letter that really goes over all the genetic information and how it's impacting that patient, and how it could potentially impact other family members, and why it's important. So that way it's coming from a healthcare provider instead of that just family member. And hopefully that increases the chance of them getting screening or testing done.
Do we think that the potential of genetic therapy may encourage more people to get tested?
Yes, definitely. Because that's a question I get all the time, about gene therapy. And unfortunately, it's not something that's available for all genetic conditions. We wish it would be, but it's something that we're actively working on. So there is always opportunities for research or clinical trials.
Absolutely. So we have some gushing compliments in the Q&A spot. It's not really Q&A. It's let's hear how wonderful Dr. Birnbaum is. So Crystal's very thankful, and Lana says that you've changed her life and you're the first doctor that really gets it. And that's what a lot of our patients have to struggle with a long time out in the community. The docs don't get it. They will tell them things like shortness of breath doesn't always, it's not HCM. It could be, you just have some asthma. Or things like, well, HCM doesn't really cause chest pain. And no, you don't get pre-syncopal from HCM. And you're like, yeah, yep, this happens to us every day. This is our life. This is the way we live. So it's nice to get a team that truly understands. So Crystal does have a follow-up question about family screening. What are the current recommendations for the, let's say, under 25-year-old population and the over 25-year-old population? Who wants to cover that?
Eric, do you want to, or
Eric's turn. Okay.
I'll just
Go for it.
Okay. So if there is and Lisa, you tell me when I get this wrong. If there is a family history of early onset disease, then screening would begin earlier. Most HCM manifests in the decade after puberty, or at least that's what we think. And so generally screening would begin somewhat before puberty. So you get like a baseline echo that hopefully looks very normal. So then you've got something to compare to over time. Because if the first echo shows a septum that's a little bit thick, and then you're saying, well, gee, it's nice to have one when it was earlier and see, oh, well, at age 10, it looked like that, and it hasn't changed at age 14. So starting a little earlier is good. Every couple of years for an echo through age 25-ish, more frequently if there is some development of some kind of symptomatology. After age 25, typically the screening echo goes down to every 5 years. But again, if there's genetic testing in the family and your 10-year-old, I'm the index patient, I'm gene positive, my child is gene negative, my child never needs to go get an echo until they're, whatever age, and something else comes up that isn't HCM. And, because people do get echoes for lots of things besides HCM. So, yeah.
I didn't think there was any other purpose for them. I thought it was all for HCM. No. So generally speaking, if you have infantile onset of HCM anywhere in the family, we do recommend some very early screening with your, even right after birth. We've even had people have fetal echocardiograms. Not common, but in rare cases, it's appropriate. Most kids won't present until 5 or 7 or at puberty. It's either going to be at the early age or then it comes in at puberty. And then there was some push from some people to stop family screening at a certain age. And I'm like, guys, it's not going to work. I've seen people who's negative 30s, 40, 50, 60s, 65, pop, there it is. 55, pop, there it is. And I hate to say I've been around long enough to see a lot of people go from 20 somethings to 50 somethings, pop, there it is. So you can't stop. If you have symptoms, speak to a physician, even if you've been cleared 3 years ago. It does sometimes just trigger on. I wish we understood the why. Then we could do something to not let it turn on. But at some point, those myosins are like, we're struggling here, send in the rest to help us. And we get that hypercontractility. So what turns that on? I don't know. There was a mouse model out of Colorado 20 years ago. I still find that model very intriguing on some triggers for turning hypertrophy on. But we don't really know. So surveillance is really important. And if you've got a really difficult echocardiogram, you may need to go on to an MRI earlier to prove one way or the other whether your heart is normal or not. So got a nice screening one there. Naomi, thanks us for a statement at about 8:28. I don't know which statement it was, so you're welcome. I'm glad we made you happy. Totally on the bandwagon with Dr. Berenbaum. He was wonderful for taking care of me, says Dave. You just brought your fan club tonight. You brought the fan club. We like that. And I'm going to leave Vicky's question for last, which was a little while ago. It's a little bit unusual for me. I had an alt flow procedure with Dr. Wiley performing it. Still have shortness of breath, but much better. My brother has HCM. What might help me? Vicky, I don't know what your base diagnosis is. Does anybody want to comment on an alt flow in an HCM family? Not necessarily a patient. I don't know that I have anything to offer here.
I think we would need more information. Alt flow is a very intriguing device looking at left atrial shunting into the coronary sinus, looking for helping relieve heart failure with preserved ejection fraction, not necessarily that as a kind of a encompassing term, not specifically for HCM. And so I guess the question would be if that patient does have hypertrophic cardiomyopathy, that would potentially be something to go after. But if they don't, then these drugs wouldn't be indicated. There is the mavacamten and HFpEF trial, but we don't know the results of that.
Yeah, it's early days, and I will kind of leave us tonight with some bigger concepts and the hope that we can all come together to figure out how to do all this better. But, HCM is a space, it's very unique, but not all hearts that show up at an HCM clinic or HCM. Some of them are actual HFpEF, some of them are amyloidosis, sarcoidosis, Fabry, Dannon's disease, and in the little kids, you'll see the restopathies, and you'll see other genetic variations that cause thick hearts. So in the coming months and years, you will see HCMA turning more into the home for the big-hearted. It's going to be kind of a tagline that we're going to be using, because all thick heart should be evaluated for root cause. And the geneticists love me when I say this stuff, because they're like, yes, it's not all the same disease. And we want to get specific. We want to get into that personalized medicine. We want to make sure that the right thick heart gets the right procedure, the right drug, the right therapy. And in many of these cases, you can normalize cardiac function. And getting diagnosed isn't the pathway to get labeled with something. It's the path to restore and preserve your health. And we're hoping we can get that message through to families. And we really do appreciate the partnership for all the years that we've had at KU. You guys were actually my last in-person regional meeting pre-COVID. I shut it down with KU. We need to bring it back in person some point. Make sure the town's still there after all of this. I hope you guys are okay. It's been a while. Been a long time. Okay, any final, oh, wait, we got another one. The whole KU team is amazing. We have a special appreciation for Dr. Rodler. You got a shout out. So yay. Okay. Julie, Stacy, thanks for the back end help for tonight. Thank you all for joining us. Sorry we weren't able to be live on social tonight. We will post this shortly, and then we'll get some more comments and feedback. Everybody will know that they can come back and ask us questions, and we'll forward them along. And they have your contact information. And again, I remind all of our partners and patients and everybody out there, clinical trials are our path to the future. We're gonna need everybody to step up. So please keep yourself open to conversations about clinical trials that you might be a candidate for. And thank you and good night to all.
Thank you all.
Thanks, guys. Bye-bye.
Good night.
Good night.
Thanks.